Good afternoon. My name is Ilona Kickbusch. I'm the director of the Global Health Center here. For those of us that have just joined us this afternoon, you might know that we had a discussion this morning, a more academic discussion at the symposium, because this symposium has been organized on occasion of a Swiss research grant from the SNIS that we had received to explore gridlock in global health governance. And those of you that were here this morning will know that we touched upon many different governance issues, some of which I'm sure we're going to revisit also here, but with a specific slant. And our slant is really leadership, and in particular, political leadership. And we felt that it would be very important to also discuss leadership with leaders of organizations, leading diplomats and representatives of countries who are starting to take a lead. And therefore, our conversation will very much be around that. Of course, there are very many different definitions of leadership, and I will refrain from giving one because I'm going to ask my panelists how they define leadership and political leadership as we go through our discussions. You will have seen in our program and the list of biographies that we gave you what an extraordinary panel we have here. But I actually looked at them at second instance, not only in terms of the very distinguished positions they have now, the head of external relations, Assistant Director General Michel Boccoz at the WHO, Michel Sidibé, the head of UNAIDS, and His Excellency Ambassador Chander, the ambassador here to the United Nations. But I said, what did they actually do? What did they study before they became this? Because that's also a discussion in at least global health leadership. Do we need new kinds of people? Do we need new kinds of skills? Do we need to go beyond the medical expertise, if I can be simplistic for a minute? And if you look at the biographies of the panelists, we have a political economist, we have a diplomat trained at the highest schools in France, the famous INA, that has really some of the most distinguished French politicians come out of that school. And we have a historian and lawyer. So we have quite an interdisciplinary group here, and all of which are, of course, in their own way, whether they're formally called diplomats or not, have experience in diplomacy. But let me start with that question and maybe ask Ambassador Chander first. How would you define political leadership, Ambassador? How do you know a political leader when you see one? Could you take the...
Oh, sure. Thank you, Professor Ilona. Very happy to be here. Defining political leadership, I think basically when you have basic principles, basic goals, and you want to get the job done, I think that is leadership. And the ability to carry, as many as possible of the stakeholders who are crucial in getting the job done. So very briefly, that's how I would define political leadership.
Michelle?
Thank you. Yes, I think that to have political leadership, well, you have to have a right mandate. You have to be recognized, and you have to assert yourself and be recognized and admitted by others. You have to have clear objectives, so know where you are leading the process, build on results as well. And there's a question of reputation, I think, that is very important in terms of leadership.
And are men better at political leadership because there seem to be more of them? What is this gender gap?
Well, I don't know if you can relate quality and quantity. I'm not certain. Well, it goes both ways.
Michel, how do you define political leadership?
Ilona, let me just thank you. It's a a privilege for me to be here, but I am very happy to see my big brother, Michael Merson, sitting there. He's humbling to be with people like you. You have been at the forefront, and you're a mentor for me, and I want to just acknowledge that. For me, political leadership is about accountability to people. Is about people who are capable really to drive a change for the people who are left behind. So for me, if I am not seeing that, and I'm not seeing this capacity to go to people who are left behind, people who don't have voice, whatever representation you can have will not make me following you.
Thank you, Ambassador. How does a country show political leadership, particularly within the UN context?
For me, the most important thing as regards India, given its size, given the population, nearly 1/5 of the world's population. So if you have your house in order, and if you can get the basics right, I think you're really contributing to, in a sense, to the global order. So that is what I would see as leadership begins at home. But yes, but at the same time, if you can organize yourself in a manner that you take on board the interests of the others, and if you can assist them in achieving the same goals that you've set for yourselves, I think that is maximizing the gains. So that would be political leadership at the international level.
We discussed this morning, Ambassador, that there is a shift in the world. Some people talk about a power shift. They say that the non-Western world is moving in a variety of new ways, is taking responsibility, but is also changing the rules of the game. And so, of course, there is a discussion, how much will that influence global health? And therefore, there's quite a discussion which countries, which emerging powers, economies are showing political leadership at different points in time. Of course, in the past, we saw Brazil do a lot of that in relation to HIV/AIDS with making the medicines accessible. India then following through also with generic medicines, of course, playing a very important role. We also discussed that often these countries, when global health is discussed, do not get enough credit for how much innovation they actually contributed to global health. And maybe you would like to come back to that afterwards, Michel. But what I'd like to know from you, Ambassador, when we speak about countries that are now playing a strong role in global health, one very frequently talks about China, which was also the case this morning, but much more rarely speaks about India, despite many things going on there. So could you tell us a bit about that? Is there an explicit, and the Director General, Tedros, is of course in India as we speak here. So could you tell us a bit about what role does global health play in India? How important is it for the Prime Minister? How does India play this leadership role? How does it interpret it?
Well, to start off with the cue that you have given to me about the presence of the Director General of the World Health Organization in India, this is India's anti-TB campaign. The Prime Minister has advanced the agenda of the 2030 SDGs to end TB in 2025. And with the presence of the Director General today, he's launched this in a mission mode to end tuberculosis. I think our disease burden, our contribution, if you could call it, is around 2.2 million people with TB. And coming to the leadership role, he's also announced that any country which seeks India's assistance in terms of provision of anti-TB medicines, India would be willing to consider that positively. I mean, it's an open invitation made in the presence of the Director General. So I think that also underscores our firm belief in access to medicines, safe, quality, affordable medicines, and the fact that this is critical for universal health coverage. You did refer to the fact that 80% of, the generic medicines, yes, 80% of the world's generic medicines are produced in India, and it is described as the pharmacy of the developing world. The other aspect which I think I can refer to is the production of vaccines. In fact, 60% of the global vaccines are manufactured in India. And it's their price competitiveness, their quality, which makes it a win-win situation for India and for the countries that are utilizing our products. So there you are. That's one example of practical leadership. The other one, which Michel Sidibé would be, I think that's our favorite topic of discussion. In 1999, when HIV/AIDS was declared a global pandemic, the cost of the antiretroviral therapy was $10,000. Yeah, he likes to quote 15,000, but and today it's $60. I mean, the comparison is, well, there's no comparison actually in terms of the pricing coming down from $10,000 to $60. It was effectively a death sentence for anybody, because even today, for somebody to afford medicines worth $10,000, it is effectively saying that, look, sorry, we give up on you. And essentially for the profit motive. So I think India's contribution, and in particular the company Cipla, it really drove down the prices. I think that's been a path-breaking, a leadership gesture on the part of India. And that continues to date with the Prime Minister's announcement about the first line of anti-TB drugs. So similarly, in other fields, I could probably go on, but maybe in the course of a conversation, we could return to this topic.
Thank you very much. Michel, you referred to that country, this Michel now, okay?
I was thinking it's you.
Because you referred also particularly to the access to medicines issue, of course. But I wanted to pick up there to say, at what point of the history of UNAIDS did political leadership by a specific country or by a group of countries make a real difference?
I think the beauty of this response, the journey was characterized by a movement coming from the bottom. People who were refusing injustice, starting with a few gay people, were not accepting. That's part of leadership, is a political leadership, trying to come as a patient and imposing to the government that they need to fulfill their accountability vis-à-vis them. It's the first time in the history of any disease that we saw completely patient taking over, trying to come and ask for change. And that's brought us to a major civil society movement, brought us also what I can talk about activism in science. For the first time, we saw innovation, disruptive innovation. He was talking about the price going down. For the first time, we show to the people that SOP can change, that a patient can ask to government that will not wait for 2 years, 3 years to make you validating the drugs to be helping us. So we move from 10 years to days on that one. But what was the most interesting in this disruptive innovation is also the fact that we moved from a few years' time from 18 pills, I think Michael is here, 18 pills, even 2 times a day for the patient, to 1 pill today. So which changed completely the dynamic. So in the course of this movement, I can just say that around 2001, we saw a big shift due to the fact that leaders from West, I can say that, particularly the President Bush, decided to brought this sense of urgency by saying we cannot accept that drugs will be in the north, people will be dying in the south, and we have resources, we need to put this resource. So we saw change with All Brut. For the first time, you remember, with Kofi Annan, taking these issues to Security Council. It was the first disease to the Security Council, discussed as a security issues. We saw Museveni those days breaking the conspiracy of silence, giving face to people who are dying from HIV to come out to create their associations. I want to say that it's a combination, but 2001 was a turning moment. 2002, a global fund has been created. So it's in global health, I think personally we can learn a lot from this shift from just being driven by government, driven by medical services, to see passion central and people-central approach. I can come back later on human rights issues, the positioning of women on this agenda. So many things which can go on that one.
Yeah, so thank you for that very, very critical point, Michel, to really highlight that political leadership is, of course, not just exerted by people who might be defined as politicians, who might head a government or sit in parliament, etc. Even though increasingly we do say we feel that in order to move global health forward, now that we have the strength of the civil society movement, we need to have parliamentarians on board much more. And we do feel, and it's been a theme, and now I come to Michel, at the WHO under its new leadership, that it seems critical to also take the issue of health and global health beyond the ministers of health, not discrediting them, but in order to support them to the heads of state, to new or other organizations like the G20, etc., etc. Could you share with us some of that rationale around that and how Dr. Tedros is approaching that? And also what's the feeling, in what way must the organization as a whole act towards that kind of goal, not just a few people on the top? Please, Michel.
Yes, indeed. There is a change, in fact, in the global health policies and the global health vision. First of all, there is a global commitment throughout the world through the SDGs, and we all are committed to reaching results in 2030. In health, obviously, we have SDG 3, but we have practically health-related outcomes in all the other SDGs. So there is a sort of more overall, more global vision. That doesn't mean that we don't work at country level. We don't work with countries. We do. And I mean, WHO is a government-based organizations. The governments are our governing bodies. They are our leaders. They give us our directions, and we discuss that with them. But we are guided by this more global vision that we have to deliver together. And indeed, that goes beyond health. That goes and covers a number of other areas. I mean, obviously, education, which is absolutely key, but then environment, but then quite a number of other areas. And that leads us to reach also beyond our normal counterparts, which are the ministries of health, into a more global vision with relations with government. So this is more broadly this kind of vision of where we want to go, what we want to achieve, how we want to deliver on health. And if you look at the new leadership role in WHO, first of all, WHO's role has been defined by the Constitution. And I always carry that document with me because I think it's really inspiring. If you think it's been written in 1948, and particularly if you read the preamble of the Constitution, I think it gives you very broad directions of what it is that the vision of health and the vision of health also contributing to peace and security, for example, was. So it was already a broad vision. And this Constitution also gives WHO a leading role, which it has or has not actually performed over the years for lots of different reasons. The Constitution is very ambitious, and somehow there are very high expectations for WHO, and at the same time there's a very strong competition. We are in a very fragmented global health, what we call the global health architecture. I always say I would like to see who the architect is or how it works, because it is in fact very fragmented. But we need to have this kind of leadership. So our new program, the new strategy for WHO, which has been validated by our executive board and will have to be approved by the World Health Assembly, by all our member states, goes into that direction of having a sort of more global leadership. And that covers what we call the 3 billion, the triple billion, which obviously triple billions mean having 1 billion more people under universal health coverage, which is a really basic fundamental right of access to health for people, and the most vulnerable people in particular. We have global health security, which is the emergencies, so 1 billion more people being made safe from emergencies, and 1 billion more people living healthier lives with 5 platforms. Obviously, as you can imagine, this triple billion is not WHO on its own, and it's not going to be only the health ministries. It has to be a sort of more global mobilization to deliver on that. And that's what we want to deliver upon. And if we want to be on track for 2030, for the SDGs to deliver on that, that's what we need to do. So it sounds like an ambitious agenda, but that's the agenda we are all committed to, and we have to deliver. So what WHO does now is to take this leadership into actually delivering on the commitments and bringing everybody together at all levels and addressing indeed heads of states and governments, prime ministers, ministers of health, because we know that we need the finances to be able to deliver on that, but also more technical ministries, because there's really this health agenda across the board.
Thank you. Ambassador, please.
Thank you. Just 2 points. I was serving in a place recently, and I did receive a letter, and pointing to my friend Michel Sidibé's point, from the AIDS Association of that country, petitioning me that, look, our country is about to stop the import of ART from India, and we would want you to kind of lobby with them that this supply shouldn't be interrupted. So that is just one point about the demand-driven, actually, from below and from the people who are actually affected. Yes, and Madam, you mentioned about 1 billion. We are ready to contribute about 500 million because the Prime Minister has announced the National Health Protection Plan. This is covering about 100 million most vulnerable families, which is coming out to about 500 million people. So that is been described by the Director General himself as one of the biggest universal health coverage programs globally.
Thank you, Ambassador. If you could just hold on to the mic. I was going to ask you also, following on from Michel's points, there are, of course, now a whole range of global institutions, political clubs, meetings of countries that initially did not speak health, mainly spoke economics, like the G20. Then, of course, the health agenda has taken an ever larger part also of the BRICS agenda, moving also beyond just the health ministers meeting to others. There are new kinds of meetings like India, Africa, China, Africa, etc. How do you see that developing, first of all? How useful do you think is that? The G20 has now decided to continue the health discussions in Argentina also, and have a health ministers meeting in autumn, I believe. So some are a bit afraid that this leads to a kind of parallel multilateralism, that these things don't come together then again, and they should, I guess, WHO would say, come together in supporting the agendas that countries have set through the World Health Assembly mechanism. How do you see that interface, and how particularly does India contribute to it as a very active G20 member, very active BRICS member, etc.?
Thank you. No, I think the important point there is convergence. I mean, if there are multiple platforms, but as long as your goals are the same, and there are practical solutions that are put forward, if there is greater kind of unanimity on the goals to be achieved and across different political platforms, so I think that's even better, because if you can have innovative suggestions coming up, and if there is a willingness to talk to put your money where the mouth is. One example about how you put a partnership together is CEPI. The Coalition of Enhanced Emergency Preparedness. This is for development of vaccines for emerging infectious diseases. So you have Norway, you have India, the World Economic Forum. If I'm not mistaken, it's the Gates Foundation and there's one other, Wellcome Trust. Yeah, that's right. So that precisely is a perfect example of how you are putting together, actors from across different, multiple stakeholders who would want to make a difference on the ground. And this is an anticipation of the next breakout. And I must also compliment the Director General, because I think he's put WHO on a war footing in terms of emerging pandemics, because I do believe there is a screen in the WHO where, you know, the potential threats which could develop into pandemics are being monitored very closely, and also action is being taken well in advance, because I think that addresses the issue of the WHO not being nimble enough. So I think that's the right direction to go in.
So what can we learn from UNAIDS in terms of political leadership? You already raised one issue, Michel, and that is, you know, listen to civil society, work with civil society. What are other partners, voices, etc., that emerged in those, in the history of UNAIDS that really made a difference, and where sometimes when you look at other parts of global health governance, you sort of say, my gosh, if they'd only do this. Because we asked this morning also, do different areas of global health, we looked at health security, AMR and AIDS, do they actually learn from each other, or do they sort of stay in their own, not just disease silos, but let's say organizational constructs in a way? What can be learned? What was your major experience?
Ilona, that is a very excellent question. I want just to say that we need to probably move from a disease-specific approach to people-centered approach. I think that is very fundamental, because what I saw, we would have never been able to deal with vulnerabilities, particularly people like I was talking about, gay populations. I'm talking about people who inject drugs. I'm talking about sex workers. I'm talking about all those people who have been left or pushed back from the mainstream of the agenda. I'm talking about adolescent girls in southern part of Africa. Unless we are capable to really move from just disease-specific to put people at the center of our approach, we'll not be able to really deal with those fragilities. And that's first things I personally feel we need to think about. Secondly, I think we need to think about our delivery system. The delivery system we have today, I was with Margaret in West Africa when we have Ebola crisis. And I can tell you, you will never be able to deal with global health security if you don't manage individual health risk. Means what? Means that we need to transfer competencies down there. Means what? We need to have a community health worker who could really be able to create a new subsystem to be close to people where issues are coming out. Third, what we learn is that you cannot, if you don't make medicine affordable, if you don't have a notion of public goods in our debate, you cannot have a global health which will be working for poor people. I just came from Saskatoon in northwest of Canada, minus 43. And I can tell you, with those First Nation people, they have 11 times more HIV cases than national average, 31 times more tuberculosis than national. So those fragile communities, you find them from Baltimore to Bamako. I came from Oima in Uganda, border of DRC. We were just there 3 days ago. 120,000 migrant population coming from DRC, South Sudan, in small areas of 2.2 million people. So if you don't deal with those vulnerabilities, you don't address those issues as a public health issues, I don't think that's what AIDS help us to do. Literacy, making sure that we have a treatment literacy in communities. Change completely the nature of treatment. Michael is sitting here. Change completely, because the person can deal with his treatment in different way. If we are just waiting to make sure that only doctors could be able to deliver, waiting for people to come, we would have not have 21 million people on treatment today. You have to remember that in 2001, we had less than 1,000 people on treatment in South Africa. Today, we have 4.2 million people on treatment. How you could do that with traditional service delivery system? Impossible.
Thank you. Michel, what does it then mean when WHO now says in its general program of work and also in the political statements by the Director General that we will be country-focused? How do you explain that to somebody? What does that mean? How can an organization in Geneva be country-focused?
First of all, I think I had forgotten to answer one of your questions a moment ago. It was also on the sort of more economic dimension of G20 and G7. I may start with that, and then I will go to countries. One of the things we try to do, particularly through the G20, is to say that take things from an economic angle. And health is not a cost. It shouldn't be considered as a cost. It should be considered as an investment. And this is very much what we have pleaded. And you see that increases in quality of life, in healthier lives, allowing children to have full access to education without having, problems with stunting or wasting or a number of things. I mean, the increase in terms of GDP is almost immediate. In terms of employment, and we know that we would need to create employment, and there was this very good report in the UN General Assembly of employment in health and economic growth. We know we need to create 40 million new jobs in the health sector by 2030, and 70% of health workers are women, so that means it's going to help us in development. So I really wanted to flag that, because it's very important that now leaders also consider that health really is an investment, and that will help their country grow faster and better, and that will help them grow into the future and become more prosperous. Now, what about country focus? Indeed, we've had an organization that has been for years Geneva-based, largely, then with regions and country level. So we always heard that this was an organization with 3 layers, and that's not what it is, and that's not what it should be. What it should be based upon, as I said, governments are in the heart of things. Governments are playing a key role, and so we should be looking at what happens at country level and what are the needs at country level, what is expected of WHO at country level, and start from there. So we're really reversing what we call reversing the pyramid. It's not starting from what we do at headquarters, but really started by what are the expectations, what are the needs, what it is that we need to deliver at country level, and how do we get organized to do that, which will mean probably a lot of changes in the organization, in the way we work, where people are. It would mean having some mobility within the organization and making sure that the functions are at the right level. It doesn't mean that everything should be at country level, but it should mean that that is where we start building our program. This is where we also want to start building our budget from what is needed in countries, and then we collect all that, and then we start escalating up to see how we build the budget to be able to deliver. And we know that countries are playing a key role. If you take universal health coverage, and you mentioned it, Ambassador, and explaining the key role that India plays in that, and thank you very much for this very strong effort. We know very well also that the spending is going to be mostly domestic spending. 85% of the funds for universal health coverage will be domestic funding. So this is a very important factor, and if we don't start from that to build our policies, then we'll be completely cut from reality and from where it is we have to deliver. So that's really a very, very deep change. It's a culture change, it's a change in mindset, change in the way we work, and that is why we have also started a transformation process of the organization. Not a reform process, because I think this organization, as many others, have been reformed for years and years, but really a real transformation in the mode, in the way we work, and really reversing the logics of where we start from and what it is we want to deliver.
Thank you. Ambassador, what's India's position on this?
No, in fact, just want to embellish this point. One example of a very successful partnership that we had with WHO, and of course there were other partners as well, Gavi, Rotarians International, UNICEF, some philanthropies, which was the eradication of polio in India. I think somewhere around 2008 and 2009, if you looked at the literature and if you look at the articles, there was a lot of skepticism that India would be able to eradicate polio. But in 2011 was the last case, and in 2014 was the certification from WHO that India had been declared, polio-free. And not only that, I think the kind of experience we gained because of that, and again, thanks to the technical expertise provided by WHO, We are planning to use that in our efforts to eradicate TB and some other diseases as well. And I think we have enough capacity now as a result of this experience to really take this process forward. And that also gives you a certain level of confidence that, yes, if you've done that, then certainly the other targets can also be, and there's a fair chance that you can meet them.
And so how can the country office of WHO contribute best to these national goals?
To the international, or national or international, sorry?
Well, I mean, the international goals, in this case, tuberculosis, of course, match with the international and the national goals, and particularly if large countries like India or China resolve these problems nationally, then, you know, the global statistic makes room. But Michel was indicating that this relationship between WHO and countries is changing, that it can become more productive, that each partner can, in a way, do something differently and do it better. And there seems to be a strong will there from WHO to move in that direction. So if I look at such an important member state as India, what are your expectations?
I think it's a constant process of interaction. It's a constant process of alignment. And of course, we believe in the centrality of WHO's leadership in terms of driving the global health agenda. But yes, there are aspects of the WHO's functioning. For example, the budgetary situation. I mean, if 80% of the budget is from voluntary tied funding, then clearly there's very little room for maneuver. So if you had more of untied funding, then you would be more responsive to the general demand of the member states, where there is broader consensus on issues. So I think that would be one direction to go down.
But if we talk about funding, and I go back, to this shift in the world also, where countries are economically developing, there was obviously a suggestion to increase the SS contributions of WHO. There is the suggestion that countries like China, like India, like Korea, like others, should also be higher financial contributors to the organization. There is a fear, it was discussed this morning, that a big gap will be left perhaps by the United States if the present signals are correct. And probably everyone has noted that Mr. Tillerson is no longer Secretary of State, and that there is a big shift there. So where does India position itself on these kind of issues? Not on, you don't have to speak on Trump. No, I was the WHO ones. So don't misunderstand me. I was speaking about the funding gap. But
the funding gap, there was this exercise carried out where I think the recommendation was that the SS contribution should go up by 10%. But eventually, obviously, there has to be agreement amongst the member states. So they settled on 3% increase in the SS contributions, which was just a couple of years ago. But yes, I think India has been always willing to step up to the plate. I think Prime Minister's announcement today that we would be meeting the cost of the first line of anti-TB medicines. So I guess if you were to monetize that, that would amount to quite a substantial package. And he's made an open offer to any country that is desirous of having this line of treatment, and the sourcing of the drugs from India would not be an issue, and we would respond positively. So therefore, in-kind contribution, sometimes the expertise, and sometimes the experience that you gain. For example, the polio eradication. How is it that we reached out? How is it that we ensured that there were 3 lines of checks to ensure that no one was left behind? And in a country like India, where you can exist in 3 different centuries on the same day, it was quite a challenge.
No, and I think that indication that you just gave, Ambassador, is very, very important, because we tend in global health sometimes to look only at that famous graph, that shows you the increase in global health funding, and at present now, the end of it, and maybe it's going down. But there is little measurement of the in-kind contributions, the South-South cooperation, different types of money flows, perhaps also than the normal donor-recipient relationship. And that is probably one of the challenges we also have in global health governance, in as we measure, in quotes, contributions, that we need to be much broader in how we consider those contributions. It can also be, you know, if I, in this case, think of China, I don't know about Indian figures, an enormous amount of professional training for people from developing countries to be trained, you know, in various areas of health and medicine, for example. And of course, all those kind of investments are not reflected in some of the accounting mechanisms that we have. So I think your point was very, very important. Michel, how do you see this whole funding situation emerging? Are we too focused on money and global health? Should we be focused more on money? And what kind of money? How should it flow? What's your experience also in UNAIDS and with AIDS in general?
I think we have to be realistic. Without money, we will not be able to achieve our goals. But what I learned from my own experience, when I joined Peter Piotr, who was my boss, and we were having those days just $300 million to fight this epidemic. But because we were capable to come with clear goals, with a result-oriented approach, today I can say that we have $22 billion on the fight against HIV/AIDS. But the interesting part is that we saw the pattern, that we saw clearly that this is not sustainable, that we need to preempt. We need to work with the Minister of Finance. We started 5 years ago. I produced the report to go to African Union to show to them that we have a potential risk here in terms of sustaining our gain if we don't have a shared responsibility agenda. What I can say today it is the only disease where you have a 57% of the total resources out of those 22 billions coming from domestic. We are not saying that it will be replaced, but we have to really pay attention to that. When I'm traveling in US, when I'm going to different places, people are telling us for how long we'll pay the cost of the medicine. If tomorrow we have any, I just came from Zambia, almost 90% of the people who are on treatment, 900,000 people on treatment, are on treatment based on resources coming from outside. If tomorrow we have any problem, we can have a collapse on this whole program. We will be seeing people dying. Results are there. We have been able to reduce by 50% the mortality rate. We have been seeing reduction of new infection. We are seeing countries after countries saying to us that they don't have babies born with HIV. But this funding, we need to have an holistic approach about that, to try to work with the countries to come with a sustainability transition plan, engaging Minister of Finance. Like you said, they don't see health as an investment. Most of them are seeing health as a cost, because also it's our problem. We have not been able to show impact. When we are saying to the Minister of Finance, coverage is increasing, now I have more people on that, for them that is not an impact. We need to put more analysis on impact, showing that we are saving life of people, then we are making difference in their economy. Life expectancy, for example, is a very interesting, complex indicator, as you know. And we have not been able to show correlation with our effort and the life expectancies in many places.
Michel, I'd like to stay with the financing because, again, Dr. Tedros has made a number of statements where he said, yes, I'm deeply committed, of course, to ensure sustainable funding of the WHO, but I see my responsibility broader in relation of, in any case, the broader SDG 3 and its achievement, and that includes HIV/AIDS and a lot of other disease areas and, of course, other SDG areas. And he says, I also have to be a voice for the financing of global health in general. How is that debate progressing? How is it being moved forward? what are we to expect in terms of this? It's an enormous shift of thinking if a head of organization says, it's not just about me, because, like that yellow book says, because the responsibility for WHO is health in general, not just an organizational responsibility. Can you tell us more about that?
Yeah, absolutely. I mean, this is a completely different vision. As I said, the general program of work, which is a 5-year strategy, is much more global. It's not just on what WHO needs to deliver, but what needs to be delivered across the health agenda, and we're not going to do it on our own. And in that case, we must have a more global vision and try to have also, in terms of funding, a much more global vision. Obviously, the country role is absolutely central. I mean, domestic resources are playing a much larger role than they were. But even in terms of international funding and resource mobilization, we have to work across the board. We have to work together. We have to see how we can get organized in a better way and who can deliver in a better way. You were talking also about impact and measuring results, Michel, and this is very important, and that's what we are aiming at the moment. We're shifting from outputs into outcomes and impact, and we're working a lot on measuring impact and indicators, and we're using the SDG indicators for what WHO is going to deliver upon, but WHO will have to deliver with partners, with UNAIDS, with the Global Fund, with Gavi, with countries and others. And at the moment, we are working also with our partners and in the other organization. We have a series of contacts. We've just had a contact with Global Fund. We also have contacts with Gavi planned next week. I've met GFF in Washington, recently. So we're trying to see how to coordinate, how to work in the sort of partnership model and not as a competition, but to be sure that we can manage to fund all together the needs and to make sure that everybody can have their shares. So that's very much what WHO wants to do, what Dr. Tedros has done, he's continue to do. WHO will have a financing moment in October, where we will be presenting those more global achievements that we have to have as an international community, and with domestic and a lot of support from the national governments. And that would be one moment, but we will be pleading at the same time for GFF, that should have also their replenishment further, and Global Fund and Gavi, and how to deliver collectively and how to have a holistic vision, not to have it split into fragments here and there, but to try and see how we can all collectively have a more holistic vision on what it is we need to do to fund health together. One of the points made by Dr. Tedros as well, and I think is very important, is that we've had also a very fragmented vision of funding at the moment, that very often we had funding from specific programs or specific lines, and this is not really very helping in having achieving better impact. We tend to be too fragmented. We don't have the global objective, the more strategic vision in view, and we need to have now more quality funding also that would allow us to focus where we need to bring the funds and to have some flexibility. So that's what we are pleading with all the donors, the traditional donors and non-traditional donors. I think countries that are not traditional donors, but also high net worth individual, also private sector, also private foundations. I mean, all kinds of innovative funding. In all kinds of ways, and trying to make sure that we politically put this very high on the agenda, and that the donors understand that this is global health that is at stake, and we have to tackle it from a much more holistic approach.
Thank you. Michel, at one stage you suggested 3 health organizations. And of course, that's my role. And we had a question in the morning, what should the future health architecture look like? We did speak critically about the term architecture. Michel,
yes,
you also used it. We said it's less of a building, with the Greek columns or whatever, or even a more progressive architecture type thing. But it's more of a system that needs to interface in a very, very specific way. But I mean, UNAIDS has had, 6 and more partners over the years. You know something about coordination. You know something about money. So share some of those experiences and maybe a bit of a future perspective with us.
I think, Ilona, I personally feel that if we want to project ourselves out of this room, and learning from the experience we have outside, what we need is a healthy society. I think we cannot just continue to focus on only disease and disease. We know that the lesson we learn from our experience is that if you don't deal with lifestyles of people, if you don't deal with the issues of prevention, you don't deal with practice in the society, you don't deal with behavioral change, you don't deal with all those fundamental issues, the health of the people in the future will be very critical for us. Our whatever architecture you call it, will have a problem. We'll have to deal with the billions of people who are shifting today. They are taking sugar. They are taking, all these NCDs and others will be growing in. I'm traveling in Africa. I'm seeing we are not talking about millions of people. We're talking about billions. So we need to really start building those blocks today. We need to learn from our experience on HIV/AIDS how to deal with those issues. Now your questions is certainly important. Why I wrote this paper 5 years back to provoke people, and it's because I was seeing these multiplicities of structures. Tomorrow you cannot come with just a new organization because you have Ebola. After tomorrow, another organization because you have this disease. So I said this global health need to bring some orders. We cannot, what we have is obsolete. Is a very strong word, what I'm saying, and I'm part of these all things, problems. I'm not just saying that, I know. But today what we need is one very strong, clear, normative organization, which could be WHO, driven differently, responding to today's world, not being just with 1948, fantastic, but I think we are in 2021. We need really to be able to think a normative organization who can be responding to global health issues of today. But we cannot continue to have just disease financing. We need, from my point of view, one to handle health financing, because today is fine. I was in Ebola. Let's just give you an example. People were dying. We were running every single places to get dollars to address Ebola when we have billions in global fund. It's not global fund fault because it was designed for AIDS, malaria, TB. So, and when you're safe from TB or HIV and you die from Ebola, I don't see the point. So for me, you're not having any impact. And the third one, like I said, we need a global advocacy and accountability organization on health today, where we can learn from UNAIDS experience. We can evolve on that one. I'm leading H6 now. A Secretary General asked me for the next 2 years to lead H6, which is a coordination between WHO, UNICEF, UN Women, UNAIDS, Global, UNFPA, and World Bank. And my aim is to really use the new framework of UN reform of Secretary General to think about how we can really be able to have a cross-cutting approach. If we want to deal with adolescent today, WHO is on adolescent, UNFPA adolescent, UNICEF adolescent, UN Women adolescent, UNAIDS adolescent, World Bank adolescent. But we can take that cross-cutting approach and have a country focus and not duplicate and be able to deliver on that. So I believe we need orders in really, don't call architecture, but mechanism of delivering services for people in the ground.
Thank you. Ambassador, would that make your life easier?
We talked about architects and architecture, but I see a standing edifice, as the as the Yellow Book actually describes it very articulately. It provides for a lot of possibilities of taking on board different opinions and collaborating. And I'm also looking at the, let's say, political leadership shown over the last 7-8 years in the UN. For example, starting with the UNGA high-level political declaration on the NCDs, 2011. Then that led to the WHO Global Action Plan in 2013. Targets and indicators are indicated there. 2016 on antimicrobial resistance. 2016, the high-level panel on access to medicines. This year, we are having in September the GA meet on tuberculosis. So across the board, you see a convergence. You see the political leadership across the globe taking a stand on the leading health issues. And we are all very familiar about the process of these international negotiations. I think everybody has a say in that, whether it's civil society, whether it's philanthropies. There is extensive consultation which is carried out. So therefore, what you arrive at is actually a consensus opinion on how best to tackle a disease, or other health emergencies. So I think we are seeing a paradigm shift in there being a global consensus on tackling the major diseases. There are new players who have innovation, who have financial resources, which they are willing to commit, and this is for the greater good of humanity. So I would tend to be quite optimistic about where we're heading, how global health issues are being tackled, and I think I've cited enough examples. Obviously, I would do that pertaining to India, whether it's polio, whether how we are trying to tackle TB, and incidentally, HIV/AIDS from 2010. The incidence of new cases have come down by 46% in India, and other AIDS-related cases by about 22%. So quite clearly, we are getting somewhere. So from that point of view, but just to introduce, if you're looking slightly ahead into the future, at least in India, whether it's financial inclusion or delivery of services, the mobile platform, I think, is going to play a very crucial role. So in terms of digital health, and that is something that we are piloting a resolution in the WHO with a couple of other countries. And in the India's National Health Plan 2017, we are setting up a digital authority which will in fact facilitate the introduction of digital health technologies. With this e-health or m-health, I think that is the way to go. And particularly for India, because while the literacy rate might still be about 70, 72%, but we have a mobile subscriber base of nearly 800 million. And we've just become the largest market for smartphones. Clearly, if you want to reach the last mile connectivity, I think for India, the mobile platform will be very, very significant. And sorry, if I could just add about one aspect which we have not touched upon. This is traditional and complementary medicine. And of course, top of the list there would be yoga. And as you would recall, in 2014, we had the UN declaring 21st of June as the International Day of Yoga. And we are in a project collaboration agreement with WHO, which was signed 2016 to 20, where we have actually seconded a yoga, or a traditional health systems expert for 4 years to develop certain packages where we can then project as to how these traditional systems can be then brought into the mainstream.
Thank you. Michel, when will WHO have a ADG on digital transformation?
That's a good point. Indeed, the world is changing, and I think that we can just welcome that, because it offers a number of really great potentials and possibilities, and particularly potential to access people who were not easily accessed, because these technologies are now spreading the world over, and that's a very good point. I would concur also with what the ambassador has just said, Michel has just said. We've achieved results, and I think that is the most important thing that we have to focus upon. Over the last, probably the last 15 years or so, there's been a huge increase in political attention given to health. There's been a lot of focus on it, and actually achieving results as a result of collaborations, as a result of political will as a result of also more funding, and the results also of having better technologies, and that's across the board, better diagnostic tools, better access to quality medicines, better prices for it, and indeed all the new technologies open, and I mean e-health or m-health open and really a huge new field that we all have to explore together. And I think that would mean better access and also a lot of savings over time, I think. And so make medicine more accessible, more affordable to everybody. So yes, maybe we should create a new AGG post. It would be devoted to that. Why not? That would be part of the transformation process. And actually the transformation process in WHO is only beginning. It's not finished. So why not? That would be a very interesting idea I can bring back home to WHO.
Let me pick up on the issues that have sort of been in some of your contributions already, and that is what the SDGs call upon us to work in new and different ways with the private sector. And there are various ways of doing that. There have been a few hiccups in a recent AIDS organization around the cooperation with the private sector. And And new issues emerge around this. We've been used to thinking about working with the pharmaceutical industry. We've been used to saying, yes, we won't work with tobacco. That was reasonably straightforward, let me say it. It's becoming much more complex if we look at the NCD agenda, where it's about major food industries that don't just produce one unhealthy good, but usually a whole array of things. It's about the information technology industry that is highly privatized and has tremendous gains, particularly also from their health programs. So could I have some commentaries from you if we say, as Michel has said, we're in the 21st century now. There are new ethical issues that emerge from that around health and privacy. There's the big data issue on health. There's a lot of things that also would influence that little yellow book, I think. So where do you think those challenges are, and how are you trying to address them both within a country and internationally? How has it been for UNAIDS, Michel, the whole issue of private sector cooperation, but particularly the new types that are emerging?
I think we have a very solid experience with the private sector, because without our partnership early with the private sector, without bringing civil society to challenge the big pharma, to make sure that we can really have a generic production, to change completely bring the a pattern of reducing the price and others, we will not be where we are today. Just to give you a good example, in September, with the support of Gate Foundation, with also support of Sweden government, we have been able, UNAIDS, to negotiate, bring a volume to make the reduction of the price of dolutegravir, which is the best first-line medicine you have in the world today, which is used in US at the cost of $18,000 per person per year to $75. But it is happening today. That is the best medicine you have for first line, which could change completely the life of millions of people in 90 countries. So without public-private partnership, bringing volume from countries' levels, making sure that you can reduce the price, having Gates Foundation coming, having Sweden government and ourselves, it would have never happened. So I think you will never achieve that. I want to say that the SDGs goal without changing this type of partnership, bringing today, of course, a public-private partnership at the center of what we are doing. We should not see them as bringing money to us, but we should see them helping us to quicken the pace of action everywhere we are today, because they are critical. Innovation is coming from where? It's not coming anymore from governments. Even in India, innovation is coming from private groups, from people who are investing. We are trying to transform. How we tap on that is important. How we say that we bring regulation. But the new frontiers are all the ethical issues we need to deal with, and those are issues maybe you can talk about it more than me. But I think it's very important. These frontiers, new frontiers, are very important.
Ambassador, which parts of the Indian private sector are partners to you in global health? Does it include, I'm thinking back to the polio eradication, where you had the great support of private sector partners also, but also in the smallpox, quite extraordinary with the Tata company, etc. So who are players in India right now who might be Indian players or even global players that are part of this global health agenda? Have you been able to convince all of them? Are there some that you still want to pull on board? Are there others that are really part of it already?
If I could just preface my remarks that I think obviously it has to be a public-private partnership, but the anchoring role or the pivotal role has to be played by the state. Yeah. And once you do that, yes, and I think India, the advantage of the population size is that it's a huge market, domestic market also. Yes. So the private medical industry has also just boomed in India. To the extent that we even have medical tourism with people coming to India because of the low cost of medicines and the excellent skills available, that we have huge growth in the medical tourism industry also. But yes, I think even in the policy framework, when the government is approaching health issues, there is definitely a crucial role for the private sector as well. Quite clearly, I don't think the government can go it alone. Yes, you provide some central points around which then you can build this edifice of private healthcare, vaccines, pharmaceuticals, and incidentally, I think, if I'm not mistaken, Sumit, our I think export of pharmaceuticals close to about $18 to $20 billion every year, and that will be mostly generics. So you have the wherewithal. And increasingly, the role of civil society, the role of private entrepreneurs, innovation, it's all beginning to happen. It's converging. So yes, it's actually a very exciting time to be back home, addressing, and of course, which are very huge issues. But you need, of course, everybody to pull along, and policy frameworks do provide for multiple stakeholders to participate in the process.
Michel, we can't avoid talking about it. There's, of course, a set of rules that WHO has given itself in better and clearer cooperation with non-state actors. You've gained some experience with it now throughout the organization. How is it moving forward? Is it proving to be a helpful tool? Is it, something that you think will have to be developed over time, clarified, particularly if I can go back to the fact of these totally new actors. If we think of the IT industry with global players totally privatized, and we're all dependent on them in every way, and they're entering health more and more. And not only building their own hospitals, but in every other way, from monitoring to whatever. To what extent is that moving forward?
Well, as you know, there has been a very strong, very lively discussion in WHO for a number of years on how WHO should engage with what we call non-state actors, which might not be very transparent terms, but by that we mean actually 4 main categories of actors: civil society, philanthropies, academic and research, and private sector. And this framework has been discussed and adopted by member states, and it gives us a number of guidelines. This is called a framework for engagement, which means that this is both something that is there to protect the organizations in terms of its integrity. As you know, WHO has a very important normative role, and we must make sure that this remains independent and guided by evidence, by fact, by science, by research, and not by undue influences. So the purpose was, on one hand, to protect the organization from this kind of influence, by allowing us to have guidelines and recommendations that would be universally considered as science-based. So that was a very important role that has to be included in it. And we've been doing a process of due diligence to make sure that we didn't go into this kind of undue influence. But the other side of it is engagement also. And perhaps we have developed less the engagement side. And I think there's a scope also to be much more proactive in terms of how we're going to reach out to partners, how we're going to work more with them, how we're going to deliver on health outcomes, on impact with partners. And that's really what we are looking at the moment, having a policy of engagement on the basis of this protective framework that clearly says what it is we can do and we cannot do. Obviously, in terms of private sector, it's very clear that there are industrial sectors we're not going to engage with. I mean, tobacco has been clearly ruled out for very good reasons. And also the arms industry. We're definitely not going to engage with any of those. But then we would need to engage with, as you said, digital technologies, and actually we need to have a dialogue with pharmaceutical companies. They can deliver a number of tools that are very important for global health, and we have to look at that from a risk-benefit analysis, and we really have to make sure that if we commit and if we start engaging with these companies, it would be for a clear health benefit. So we set up a steering committee that helps us analyze the questions and the cases when they are a bit tricky. Some of them are pretty simple. Some of them are really in the sort of bit of a gray zone compared to our framework. And we need to make sure that when we decide to engage, that's going to be for a positive impact in terms of global health. So this is a new system. This is a new way of dealing with things, and it proves open and interesting. We have to engage also with the industry. We may have some divergence of views with. For example, if we take, let's say, food and beverage industry, we have to also engage in terms of reminding them what the WHO guidelines are in terms of salt, sugar, and trans fats, for example, when we talk about food. But really, basically, we have a number of partners that really can help us deliver diagnostics, drugs, quality drugs at affordable prices, IT tools. I mean, in service delivery, we really need to work also with the private sector, in diagnostic, in health workers. Also, we know that a lot of health workers are actually in the private sector, and we need to work with them, community workers and others. So there's a whole scope of partnerships that we can develop if we are very clear about making sure that the benefits and the outcome is really have a positive impact on health, and we stay within the very carefully negotiated guidelines that have been given to us.
Thank you. Michel, you said you're chairing the H6. Many of us were very concerned when the Global Fund made a recent partnership with the alcohol industry. At the same time, when WHO is taking the NCDs to the UN and is deeply troubled by the large exponential growth in NCDs, do you think there could be a couple of rules that guidelines that maybe all the members of the H6 should relate to, should adhere to, not to be in each other's way, and actually in a way reduce the credibility of the whole system?
I think is a very important issue, and we need to learn from experience. And in the future, I am sure that one of the discussion we'll have as head of those agencies is this type of discussion. How we will be able to come out with a mechanism which will guide us, which will help us to not block us to really be able to be proactively reaching out, but managing that in the way that it will not bring credibility risk for us. And I'm sure that is Tedros is thinking about it, and Arieta also, all of us, we will be certainly addressing this issue. So I think it's a very important one.
Thank you very much. I want to give you the opportunity to comment or give a question or two. Who would like to start? Yes, please. There's a mic coming, hopefully.
Thank you very much. I'm Franklin Lisk from the University of Warwick, and I used to be involved in health issues as the founding director of the ILO Global Program on HIV/AIDS and the World of Work. This is an interesting discussion, and for me, I'm particularly interested in finding a simple and easily explained approach to dealing with global health issues. From the discussion, I see three pillars: leadership, governance, and partnership. Now, with leadership, I believe that, and Michel Sidibé and I have discussed this many times in the past, I believe that we have to look at it in a broad spectrum, ranging from global right down to community level. We want to look at leadership at global, regional, national, and community level. I recall the commitment of African heads of states, I think it was about 2001 or 2002 in Abuja. I was there at the time, and there was a lot of interest and a lot of hope at the time. So for me, leadership is essentially how do we translate this into political will and commitment. So that particular pillar is very important, the leadership pillar, and it has to resonate throughout issues relating to global health governance. The second is governance itself. And governance, as far as I'm concerned, in the current climate, both global and regional, we need to look at issues of innovation. We have to come out of our cocoon. We have to come out with bold ideas. And the emphasis should be on governance innovation, which will relate to not just the structures around which decisions are taken, but the rules themselves and the guidelines. These have to be examined carefully so that innovations are introduced with respect to what can be attained, and not just the normative, but what ought to be and what can be attained. And then the third, and also the issue of equity and coordination. And then the third pillar, which I would like to comment on briefly, is partnerships, which came up. And briefly, I would say partnership has to be innovative and transformative. Partnership has to also have strong representation in terms of popular participation, which, as Michel Sidibé mentioned, deals with issues pertaining to people themselves and their perception of what is good health. So these are my observations. Thank you.
Thank you very much for adding to the discussion and reinforcing those three dimensions that I think we've talked about in a variety of ways. And maybe you want to come back to that then. Could I hear from others in the audience? There's a gentleman here, please. Maybe, David, you want to give a commentary? No?
Thank you. My name is Matthew Colburn. I did Global Health Governance with Ilona. And for Michael Sidibé, I have a question. It sounds within epidemiology, we always talk about the prevalence and the incidence. And within the WHO, we always are having a response, a treatment to the response. And when you're talking about changing for the health of the people, it sounds like prevention, which is more cost-effective and a better investment. And we, with Ambassador Chander, he was talking about how India was contacted to help another country be sure and receive the medication they needed for AIDS. And within that, I'm curious, how do you create the political will for prevention? Because most people are so concerned about the immediate need, but the reality is prevention is so much more effective and in many cost ways. And with the funding coming from individuals within states, how do you manage to make that a priority for them? Because borders are no longer something that separates health between states. So how do you create the consensus and the political will to drive the prevention efforts?
Thank you for that. Any other questions, comments? Otherwise, we'll start with this, please. Michel.
Thank you very much. I think it's a central question today because I don't see any countries, I said, in the world, and particularly in the developing world, who will be able to afford the cost of paying for NCDs. It will be so costly. If you take only cancers and others, and even with innovation, even with reduction of the prices, we calculate, for example, if Zambia should pay for only the treatment cost, it will be 3-4 times of the health total budget. So we are saying one disease. So how you will make that? We need to demonstrate clearly to political leadership that you don't have a better return on investment than that one. The difficulties we have today is that most of our investment on those countries are driven by funds coming from outside. And funds coming from outside is generally based on short-term gain. We want to demonstrate to our Congress that we give $1, look at the result of the $1. We put people on treatment, we have more people on treatment, we have less, but how we prevent that, how we change that to make our own leaders, our countries, to understand that reducing new infection, that's why I push for fast track, quickening, to make sure that we have less infection, so we are less cost, and then we will be able to control the epidemic quickly. But you will not do that without prevention, but we don't have a good, and you can help us on that also, a good analysis today showing those examples, and I think Michel is with us. We probably is one of the best in this room to talk about that, but we don't have a very well-documented example. I launched now a global coalition on prevention. One of the objectives is really to look at where we have been able to demonstrate that prevention can reduce costs, but help countries to invest on. It's very difficult for, honestly, but it is the way to go. We cannot afford. I honestly just going for making sure that we'll pay. I don't see any countries will be able to do that one. We need to combine, of course, life-saving medicine today to save life, but the way forward will be prevention. And he was talking about yoga.
No, I won't be demonstrating any asanas today. No, but I think that's one aspect where I think thanks to the 24-hour access to information, what we are having is a surfeit of information. But yes, I think there's an acute awareness about the wellness of life, stress, and probably that's one of the reasons where my colleagues have actually, piloted with other countries, of course, a resolution on mental health. In terms of stress management, and yes, that's where yoga, I think, is critical. And I'll be very frank with you from my personal perspective. I think people are more aware about yoga, and the knowledge of yoga often surpasses those of Indian diplomats. So we have actually very difficult, you can say, task to accomplish in terms of, and I'm absolutely surprised whether it's Ukraine, where I've served in, whether it's Vancouver. I think the way yoga has caught on. Obviously, not because it's Indian, but because there's a felt need to do something natural, to do something which doesn't cost you anything except your time and commitment. So clearly, I think the pressure is building. There may be a groundswell of opinion, of need for a more balanced lifestyle, whether it's vegetarianism, whether it's holistic lifestyle. I think that's something which will attract the attention of a lot of health policymakers. Yeah.
Thank you.
And perhaps just to refer back to my yellow book that Michel thinks is opposite. It's not. I mean, if you look at what is health in this yellow book, it's not prevention of disease. It's really the attainment of the better health of possible. And that means working on a number of issues like prevention, and that is very, very important. We have as one of our priorities for healthier life. I said that one of the billions that WHO is working upon at the moment is a billion more people leading healthier lives. And that's very important in terms of, indeed, prevention of non-communicable or other diseases, and also human capital, and that includes also education. And education is certainly a very important tool in matters of prevention also.
Thank you. I'd like to end our panel with a question that I believe everyone is grappling with right now, and that does need real political leadership, and that is the fact that we have more refugees, more migrants, more displaced people than ever before in the world, and that we don't have the governance structures to really deal with that. Of course, you know, the IOM has just been made a UN organization. There are discussions around a number of compacts, etc. But much of our global health discussion and our global governance debate is still based on countries, be they strong, weak, poor, fragile, whatever we call them. And if I could have some commentary from you, what needs to be done, or what important things are being done, you think, at this point in time, so that we can address this, and what kind of political leadership it needs? The refugees themselves at this stage are, you know, not going to be the voices. The many countries feel threatened, and as we spoke this morning about new nationalist movements, etc., they don't want to talk about it, and they don't want to give money for it. If anything, they'll give money for people to stay far away. But what are your views? I believe that's one of the really critical challenges in global health governance, the right to health of these people. And how do you think this should be approached? Who would like to start?
Okay, so I will start. Yeah, I think this is a major, major problem. I mean, it's not only a health problem, really, quite frankly. It's a much more global problem in terms of how to deal with this. And obviously we need to have a huge political commitment in there. I mean, absolutely. In terms of, well, first of all, why do people migrate? And lots of cases are really, sometimes it's health related, people not finding the future for their children there, but mostly it's conflict related, or it can be economic migrations related. And at the moment, this has been really left very much at the country level, and the countries have been in charge of supporting that. And we just have to have an international response to that. We're dealing with that in WHO as one of our priority concerns. As we know, we have created, as you said, we are very inventive in terms of our new ADGs road, and we have an ADG for special initiatives, which is what are the areas that we should focus upon, and in terms of leadership, in terms of what we're going to do with. And one of those is migrations and refugees, and how to make sure that those people can have access to health services. We know that during the migration, they are very often victims of violence, mostly victims of violence, really, and when they arrive in countries, they are usually in a state of trauma, and we have to deal with that. That's a very key element. There's been discussions also on their weight in public health. We very often realize that when migrants come to European countries, for example, and we realize that over time, sometimes they get infected, maybe with AIDS or other diseases that they don't necessarily have when they come. So there's a lot of misrepresentation of what it means in terms of impact for others. And that's globally something that we have to address at a very political level in terms of what we do with that. And we're looking at how we can do it from the health sector, and how we can help countries, how we can guide countries, how we can help political leaderships in dealing with at least the health aspects on how to help on those migrants and refugees. This is only a small part of a much, much, much broader picture. And what we try to do at our level is to raise awareness and to make sure that we deal with the real problems and mental health after violence, or in terms of post-traumatic stress and a number of other issues are not being dealt with properly, and we must lay a heavy emphasis on that.
And there is, of course, a resolution also from the World Health Assembly. Please, Ambassador.
Thank you. Well, in India, of course, we've played host to refugees since the time of independence in hundreds of thousands. Yes, they're all eligible for healthcare. Yes, but what you were talking about, I guess, is what's happened in the last 3 or 4 years. It's a very difficult issue to address. I suppose we'll have to come at it from different angles. Regular migration, controlled migration. Yes, and I think these issues are currently being debated in the global compacts that are being discussed. Global Compact on Migration, which we have already, I think, 3-4 months down the path in terms of negotiating the basic contents of. And the Global Compact on Refugees, we've just made a beginning. And I think these are some of the issues that would find play in these negotiations.
Thank you very much. I think it's a very important issue, because I personally feel that is beyond just what we can do in a fragmented way. And compact is something certainly welcome, but it is a political issue. It needs to be addressed in a very serious manner. I'm coming from Sahel. You know where is the Sahel. You know the situation of my country in northern part of Mali today. And believe me or not, most of the countries I've been traveling those few months, they have almost 85% of their population below 30 years old. So if you have such of a bulk of young people without job, without hope, without any mechanism which will really help them to stay where they are, I don't think you will be able just to contain that, to resolve that, because you have mechanism which will really regulate and fix them one place and not make them coming. They will come. They will come. And secondly, I came from Japan. Japan, they are planning now a future work based on life expectancy of 120. So coming back and saying until what will be the notion of working in Japan, what will be the age of retirement. When you have more and more population aging in one side with opportunities, and in other side, young population without any opportunities, but with some potential. I think we have to rethink these issues very seriously. And I want to end probably that we didn't touch to these issues so much. And thanks that you have been really putting us here. I think we need to deal with the inequities. We need to really think about inequalities. We are discussing, I'm from a continent where we have a 26 to 27% of the disease burden. We have today in Africa less than 1% of the total expenditure on health, my dear. So I don't know, we have one doctor for almost 44,000 people in Sierra Leone. So how you will change really the face of the health of people there if you don't deal with this gap, these inequities, and trying to have better redistribution, which will help us also probably to save life and to have a better global health for all of us. And that will be the foundation for health security in the future.
I hope you'll permit me to end on a note with an Indian subtext. Well, if you look at a population of 1,250 million, so we are talking about the Americas and Europe together, and multi-ethnic, multi-religious, multilingual. So you realize the dimension of the challenge that we face. But the fact that we are a democracy, and within a year, the world's largest exercise in democracy, in elections, will take place in India, where almost 850 million people who are eligible to vote will be holding the government accountable, the political class accountable. And the fact that the mean age of India is roughly about 29 years, so we're looking at a population of nearly 600 to 650 million, which is less than 30 years of age. So I think that, if you want to understand India, the dynamics of such a young population will cut across social, economic, and political sectors. And that is the dynamism which is driving India forward. And perhaps that's when we'll get noticed. To answer your first question.
Thank you. So we've gone full circle in a way, and I'm very happy we have. That in talking about leadership, we also have to talk about the political context. We have to talk about the social and economic context. We have to keep in mind that we have an enormous power shift and that new voices will demand to be heard. We've discussed that we will have totally new economic models with which we will also hopefully address global public goods. But we definitely have the basic issue at stake that's in the center of the SDGs and that Michel has raised again, that the inequalities in health and the inequalities between countries are still growing in many cases, but also that the fact that because of the impact of globalization, there has been a real problem of fear in many of the developed countries, that we are seeing a pushback in terms of global solidarity and of commitment into global issues, including global health issues. And therefore, I think we see the necessity for global health leadership in a new perspective, because it has to come from new countries. It has to come also from new kinds of partners, and it's got to come from women also. Global health has been very, very male. And we have to find a way that the voices that are not heard can also be heard, or at least then be made visible. And for me, those are really the people who are forced to be on the move, who have no home, and who have no livelihood, and in many cases, if they are young, who have no future. And therefore, your example between those people and those that are planning or to be 120 is extraordinary, and it is an issue that we will have to address in global health governance and leadership. Thank you very much to a fantastic panel. Thank you. And we have a short break, and then we'll hear all what you ever wanted to know about the history of HIV/AIDS and the creation of UNAIDS. All right, give yourself a short break.